This is Dr. Emily Knipper with Virginia Tech Carilion School of Medicine and the Anesthesiology Consultants of Virginia. Today I'm going to be discussing the paper entitled Opioid Use Disorder and Misuse, a review of the epidemiology and medical implications for pediatric anesthesiologists. Opioid use disorder has been a frequently discussed public health issue, and this article focuses particularly on specific issues for those of us who work in pediatric anesthesia. First, with a discussion of the epidemiology, and then specific clinical implications that we can use to help guide the care that we provide to the pediatric population, specifically with anesthetic care and perioperative pain management, as well as discussing the clinical implications of acute opioid overdose and accidental ingestion in children. Table 1 of the article discusses terminology that is relevant to opioid use disorder and that is used throughout the paper. I would like to highlight the term opioid use disorder. This term comes from the DSM-5, and it has essentially replaced the terms opioid abuse and opioid dependence, emphasizing evidence of impaired control, social impairment, and risky use, in addition to the pharmacologic criteria, such as the presence of withdrawal symptoms. I'm going to start the discussion on this topic with discussion of epidemiology of opioid use disorders in the United States and Canada, and then focus on international data, and lastly discuss specifics of opioid use disorder related to adolescents. I will discuss the US and Canada separately because the magnitude of the problem is greater in these two countries. For instance, with the US, while it accounts for only 4% of the world's population, it contributes to 42% of the deaths from opioid overdose in the world annually. As some background information, it is important to consider the historical context with consideration of the trends for opioid prescription practice and medical use as they relate to each other. During the years 1999 to 2010, the U.S. saw a fourfold increase in the sale of prescription opioid pain relievers. Contributing factors that have been identified include the introduction and marketing of an extended-release form of Oxycontin, and public health efforts to destigmatize and treat chronic pain with the initiation of pain as the, quote, fifth vital sign, end quote. Looking at data from this time period, we see that a parallel relationship developed between the number of opioid prescriptions given and the disordered use of available opioids, and as well as opioid adverse outcomes. With the rise in prescriptions also came a rise in opioid-related fatal overdoses, with overall deaths involving prescription opioid medicines quadrupling from 1999 to 2014. For the year 2014, 61% of all drug deaths involved an opioid, the total number of which is more than 1.5 times the number of deaths from motor vehicle-related fatalities for the same year. We see a similar situation has occurred in Canada, with the Canadian Centre on Substance Abuse and Canadian Community Epidemiology Network on Drug Abuse reporting that the number of deaths involving fentanyl had increases as high as 20-fold in certain provinces from the year 2009 to 2014. Much of this increase may be due to illicitly manufactured fentanyl. It is also important to mention that use and fatal overdoses of heroin are associated with the misuse and disordered use of licit opioids. Factors cited for the transition from prescription opioid drugs to heroin use include the lower cost and greater accessibility of heroin. Studies report that 4 out of 5 recent heroin initiates report having prior non-medical use of opioids, with a similar number of heroin users reporting being introduced to opioids through prescription drugs. With this, we've seen an increase in the heroin-related fatalities that have occurred. Switching gears to discuss global epidemiology, more than half of the world's opioid-using population lives in Asia, with the highest annual opioid use prevalence in Afghanistan. Differently from the United States, opioid use disorder worldwide is more evenly distributed between heroin and prescription opioids. While in the U.S., we see a link between the disordered use of opioids and prescription practices, worldwide, the market flow of raw opium and heroin is more strongly influenced by global politics and economics, with the illicit cultivation of opium limited to certain regions of the world, and 80% of the total global opium production occurring in Afghanistan. Recently, novel illicit opioids have been introduced, such as W18 and acetylfentanyl or acylfentanyl. These drugs are particularly dangerous given their high potency, unknown dose in illicit drug sales, relatively unstudied pharmacodynamics, and limited detection on standard drug tests, and they have already been cited as important contributors to overdose-related deaths. Among adolescents, a couple of epidemiologic points should be made. The liberalization of opioid prescribing practices seen in the 1990s affected prescriptions for adolescents and young adults as well, and also, indirectly, resulted in an increase in unused prescription opioid medications available for misuse and disordered use. Nearly 500,000 adolescents were current, within the past month, non-medical users of pain relievers in the year 2014. Also, while the disordered use and diversion of prescription opioids in the United States plateaued in the year 2010, these things actually continued to rise through 2013 amongst college students. This difference among age groups may be attributed to the fact that adolescents and young adults have been found to perceive prescribed opioids as less harmful than other illicit drugs. Regarding heroin in adolescents, heroin use has more than doubled among individuals 18 to 25 years of age over the last 10 years, along with an increase in heroin overdose-related deaths, with the highest annual increase occurring in adults 18 to 24 years of age. Changing gears, I now will discuss the clinical implications of opioid use disorder with considerations for the practice of pediatric anesthesia. A couple of important phenomena to consider in patients who are exposed to opioids on a chronic basis are differential tolerance and opioid-induced hyperalgesia, both of which can make the management of perioperative pain more challenging. First, the concept of differential tolerance. This refers to the development of variable tolerance for different opioid effects. For instance, a patient may have significant tolerance to the analgesic effect of an opioid, but minimal tolerance to its GI and respiratory effects. So a certain dose of opioid may be inadequate to treat a patient's pain, but yet still capable of causing significant respiratory depression. Secondly, the concept of opioid-induced hyperalgesia. This is a concept that has been reviewed extensively elsewhere, and here I will just mention that it is a complex clinical phenomenon characterized by nociceptive sensitization secondary to exposure to opioids. Patients with this experience increased pain levels and pain sensitivity while receiving opioids. Taken together, differential tolerance and opioid-induced hyperalgesia may lead to patients having pain that is refractory to treatment, as well as greater susceptibility to respiratory depression. Clinically, differentiating between the two of these things is difficult, that is, opioid-induced hyperalgesia and differential tolerance, but both lead to a similar result of increased risk of undesired side effects, chiefly sedation and respiratory depression with pain that is refractory to escalating doses of opioids. I'm now going to discuss some specific points for perioperative pain management. While we lack large randomized prospective trials to elucidate this field, certain best practice recommendations may be made. Preoperatively, pain management begins with a thorough assessment of a patient's current pain, coexisting conditions that can exacerbate pain such as anxiety and depression, and a thorough knowledge of the baseline pain regimen. Patients may also present on opioid agonist therapy, such as methadone or buprenorphine. This is a situation in which it may be challenging for an anesthesiologist to establish a non-judgmental and non-threatening discussion in a short amount of time prior to the operation. So asking specific and concrete questions, as well as explaining to the patient that the information is important to safely guide anesthetic treatment, can be helpful. If there is concern of opioid use disorder, the DSM-5 Opioid Use Disorder Checklist, an 11-point yes or no list, may be helpful in guiding care and identifying patients who should be referred for further assessment postoperatively. It is also helpful to discuss the patient's specific goals regarding opioids and pain relief expectations around the time of the operation. It has been found that such a discussion encourages a more adaptive response to acute pain postoperatively. Preemptive analgesia with a combination of NSAIDs, acetaminophen, clonidine, gabapentin, and anxiolysis, and the use of regional or neuraxial anesthesia should also be made preoperatively. Intraoperatively, multimodal management should be continued, with the addition of ketamine being considered. Other potentially helpful agents described in the adult literature include IV magnesium and IV dexamethasone. Postoperatively, it is important to continue multimodal treatment as well as providing baseline opioid doses in order to cover physiologic tolerance and to avoid withdrawal symptoms. Even patients who have well-working neuraxial analgesia or peripheral nerve catheters may continue to have significant opioid requirements postoperatively, depending on preoperative use, because of physiologic dependence and chronic pain that is independent of surgical pain. The paper discusses specific considerations for patients on methadone and buprenorphine, which I will not discuss here, except to mention that accidental ingestion of buprenorphine has been seen in children with the potential for fatality. Another scenario the anesthesiologist may encounter are those patients presenting with acute opioid overdose, either heroin or prescription opioids or novel formulations such as acetylfentanyl. Clinicians are likely familiar with the classic presentation of respiratory depression and stupor, but it is important to note two things. One, chest wall rigidity may be present independently of respiratory depression, and number two, non-cardiac pulmonary edema may also be present, as another factor that may contribute to the need for mechanical ventilation. Children are also susceptible to opioid poisoning through accidental ingestion. A key consideration is the possible co-formulation of the opioid with acetaminophen, requiring early treatment with acetylcysteine, as well as the possible ingestion of long-acting formulations. Again, although buprenorphine is thought to be relatively safe compared to other opioids given its ceiling effect, quote, accidental ingestion has still been seen to lead to significant respiratory depression and death in children. Something that all anesthesiologists should be cognizant of is the phenomenon of prolonged opioid use after acute exposure to opioids in the perioperative period. This is a topic that has much room for greater research, but here I will just highlight a couple of points. In adults, prolonged use after acute exposure has been identified. Risk factors for the prolonged use of legitimate prescriptions of opioids include patients self-rated as higher risk for addiction and depression at baseline. Amongst adolescents, a study looking at spinal fusion for idiopathic scoliosis showed that the duration of postoperative pain correlated with baseline levels of pain and anxiety. Specifically regarding the duration of opioid use, factors identified in prolonged opioid use after traumatic injury among adolescents included report of pre-injury marijuana use and higher baseline scores. Interestingly, the duration of opioid use did not correlate with the injury severity score. It is important for anesthesiologists to acknowledge their important role in managing postoperative pain and helping to minimize the development of chronic pain. More information is needed to help clinicians determine who may be at risk for prolonged opioid use after surgery. Also, if there is concern raised about opioid use disorder, an anesthesiologist may face the question of disclosure if the patient is a minor. Laws regarding this topic vary amongst states, with some states prohibiting disclosure and some requiring it. In conclusion, the opioid use disorder has broad implications in the United States and globally, with relevant considerations in patients of all ages. Non-medical use in the adult and adolescent population rose with the availability of prescription opioids, and younger children may be affected by accidental ingestion. Pediatric anesthesiologists are faced with the physiologic challenges associated with pain management, tolerance, hyperalgesia, all while providing safe and optimal pain management. Thank you.